Morning. Today our topic is oxygen transport, and this is oxygen transport in the blood, not in the trucks. It's in our blood, okay? Upon completion of this unit, you will be able to calculate the quantity of oxygen that dissolves in the plasma, as well as the quantity of oxygen that combines with the hemoglobin. This unit is probably one of the most difficult units in this class. It has calculations and abstract concepts of CO2. Other things we will be looking at is the O2 dissociation curve and what makes it shift to the right and to the left. We'll also explain the clinical significance of that O2 dissociation curve, and then we'll look at factors that increase or decrease CO2 transport studies. On your own time, I will let you watch this video. It's a good explanation of how the blood transports oxygen and carbon dioxide. All right, let's start with O2 transport. It's a small amount of oxygen that exists in a simple physical solution dissolved in plasma or erythrocyte intracellular fluid. The majority is carried in a chemical combination with the hemoglobin. So to find the dissolved amount of oxygen, you will take the PaO2, which you will find off a blood gas. So you'll need an arterial blood gas to be able to calculate this. You times that by most oxygen diffused into the pulmonary system will be chemically attached or bound to the hemoglobin. Okay, so this is how you calculate the bound hemoglobin. In whole blood, each gram of hemoglobin is capable of carrying 1.34 mils of O2. So if you compare, this is a good representation of how our oxygen is transported. I know you've heard the box cars are what carry the hemoglobin or carry the oxygen. So the box cars are the hemoglobin. You can see the oxygen. Okay, so together we look at the total O2 content. That is the dissolved oxygen and the bound oxygen added together. So remember, 0.003 is the dissolved factor. That's a constant. And the 1.34 mils of O2 is carried in 100% saturated. If you look at this next slide, you will see the CaO2, that's the oxygen content in the arterial side. So that's what's being delivered to the tissues. The CaO2 is being delivered to the tissues. That's your hemoglobin times your 1.34 times your SpO2. That's your bound hemoglobin. All right, let's work on a problem here. There are more of these in your book, and we'll do some more. I have some worksheets for you, but this is a practice one we will do together. So if you take we'll look at all the values here, and you're going to have to pick out which. All right, let's look at DO2. We'll start in on our O2 transport studies. This is DO2. This is oxygen delivery, okay? These are used to evaluate a patient's cardiac and ventilatory status. We'll look at the O2 that's delivered to the Okay, so if we move on to the next slide, we have another O2 transport study, and this is called the AV difference. You might hear it called the AV difference. It's the CaO2 minus your CvO2. And then we'll move on to the next one, O2 consumption. This is the amount of oxygen extracted by the tissues during a 1-minute period. Okay, so VO2 equals your cardiac output again, and now you're looking at your AV difference, so your CaO2 minus your CvO2. All right, the next thing we're going to talk about is our oxygen extraction ratio. You might call it the O2 utilization ratio or the oxygen coefficient ratio. You'll see it in multiple verbiage. So this is the O2 extraction ratio. That's what we'll call it in this class. All right, the next thing we're going to look at is SvO2. SVO2 looks at the ratio between the oxygen reserved and the oxygen delivered. So remember, we had 1,000 mils of oxygen reserve or delivered. We had 250. This slide is a good representation of what causes your SVO2 to increase or decrease. Our normal SVO2 is 70 to 75%. Okay, so if it's decreased, that could be caused by a delivery problem or a consumption problem. So here's another visual for your SVO2. Oxygen consumption has to meet your metabolic demands. So if you have fever, anxiety, pain, shivering, muscle activity, those things are going to affect your oxygen consumption. This is a All right, any questions on your O2 delivery or O2 transport? We'll kind of stop here and take a rest. You can go back and look at your notes and see if you have any questions. So I'm going to give you a 5 to 10 minute break here to go back and review what you... So if you look at the actual curve, you see it's S-shaped, kind of a abstract S, but you can kind of see it's an S-shaped curve. So in talking about tissue oxygenation, we look at the O2 dissociation curve, and it gives us clues to how the O2 is released from the hemoglobin. I guess we'll sum it up here. At a normal PaO2, a right or left shift won't affect the hemoglobin's ability to transport the O2 to the tissues, but when the PaO2 drops, the O2 won't unload or transport O2 as easy. All right, let's look at shunting. We've talked about shunting a little bit in the past. Remember, we talked about dead space ventilation. This is the dead space perfusion or wasted perfusion. We also talked about normal shunting earlier, where the Bayesian venous drainage into the left atria, or here's a good visual of how shunting happens. You see in that A slide or A box that you have oxygenated blood mixed with your pulmonary capillary blood, and then you have a ventilated alveolus. So that looks perfectly normal. Okay, and the next one, here's the left side of the heart without gas exchange, so the patient becomes hypoxic. A systemic to pulmonary shunt is a cardiac shunt, which allows or is designed to cause blood flow to the systemic circulation to the pulmonary circulation. This occurs where there's heart to the left side without gas exchange. That's what's happening here. If you have 2 to 5% anatomical shunt, that's okay. That's normal. That's where we have the Bayesian veins. We have some mixed blood going through there, things like that. That's okay. Anatomic shunts, we talked about these before. Those are just normal things that happen. Or you can be born with an anatomic shunt. You have congenital heart disease. You have a fistula in there. You have a vascular lung tumor. You might have a hole in your heart. So our shunt equation, this is another one that you're going to write down. You have the percentage of shunt over your cardiac output. That's what the QS and the QT. Remember, QT is cardiac output. In order to find that, you calculate the portion of cardiac output not taking. All right, let's look at the 4 types of hypoxia. You've heard hypoxia throughout this whole class. You know it's when the oxygen doesn't get to the tissues for metabolism. That's the definition of hypoxia. They're differentiated because your body will respond different to each type. Hypoxia. All right, that's all I have for today, and please let me know what questions you have. I have some worksheets for you to go over those calculations, and we'll continue to talk about shunting because I know that is a difficult topic.